Okay, so let's take a look at mental health professionals. We have psychiatrists who are MDs. I've referenced that. Psychologists can be PhD, PsyDs, or EDD. They do clinical and counseling work. You have counselors, usually have master's degree, and then social workers who are MSWs can also be licensed, LCSWs, licensed clinical social workers as well. And these are the different types of folks and professions that are providing therapeutic interventions to people within our communities to help them. Now, the evolution of the mental health system is important to understand. When did we start to provide this, history of mental health care? Well, there's this known idea that having an imbalance, that any organism that has an imbalance is not okay, that we need to figure out how to have balance. And again, early philosophers, thousands of years ago, were really talking about this balance between the mind and the body. In ancient Chinese writings, we also see yin and yang, female and male force, that you need to have this, balance within your diet, right? Within these two forces and within even your own identity to be able to have a balanced life. The Greeks believed in the humors or the four fluids or what have you, and suggest that we have these different bodily fluids that actually regulate our mental health. The interesting thing was even the early Greek philosophers and early Greek history, they were some of the first medical professionals as well, and did understand that the human body had different physiological reactions to these different mental health conditions. They didn't quite get it right, but they did believe in these things. The supernatural has also been thought of, right, where we definitely have had centuries and different areas of times, European Middle Ages, for example, and even today, there are some folks who are very religious and do see that sins, and demons cause mental disturbances. Humanism, illness is not due to moral defects. It's not about some type of labeling of an illness, that all people should be treated with dignity. The European Renaissance, and again, this is where humanistic psychotherapy comes in as well. And then the asylums. Asylums were places where we would contain and control or house the mentally ill in the middle of 1600s, and this went on for about 400 years, where people were housed in very inhumane conditions. Now back to those four humors in early Greek philosophy. They really kind of tried to understand that if a person had cold and dry black bile, then they had melancholy, for instance, or hot and moist blood, then they were sanguine in type. And so there was these different behaviors and characteristics of personality or even mental health concerns or mental illness that would come through based on these four humors or these four types of liquid formations that occurred within the body. All right, let's take a look at our next slide. Now, early contributors to the history of mental health and understanding that, Benjamin Rush is considered the father of American psychiatry, really started to understand the physiology as well as the mental health and building it bridges together, and really started to build frameworks of within medical schools, the world of psychiatry. Philippe Pinel was important in really understanding forms of what we now would call schizophrenia. He coined the term dementia. Today, we understand dementia as people who may have a loss of memory, but Philippe Pinel was trying to understand persons who were diagnosed with schizophrenia. Emil Kraepelin added on to the term dementia, and he's called it dementia praecox, which was more specifically to define schizophrenia as we know today. And he actually came up, understood, and was studying different types of psychiatric disorders, and he came up with an early categorical system to try to understand these different types of disorders. And even though he did not write the DSM-5 it has here, but just understand that his early categorical systems is what helped the development of the first DSM in 1952. Eugene Bleuler is the first to actually understand schizophrenia. It was earlier on in early American psychiatric history, schizophrenia was highly investigated because as a severe mental illness, there were a lot of demonstrative changes in the human mind, and so that was definitely a high area of interest. Louis Pasteur, also, who's a biological scientist, he did develop the notion of germ theory and kind of thought of the notion that illnesses were caused by germs, and so that brought into play the idea that any illness, even if it was a mental illness, could be caused by some type of biological dysfunction. So even though he was more of a biological scientist, this helped to put into play the notion that illnesses were related to biological diseases. But Louis Louis Pasteur's work did kind of fate the mental health practitioners to follow the medical model for hundreds of years thereafter. Consequently, psychiatry founded as a part of human medicine. And today in psychiatry, mental illness is considered a disease and not a disorder. And that has both, tones of like good benefits, but also some drawbacks as well. So if we understand that, these disorders are diseases of the brain, then that will help us to reduce the stigma. But if we call them diseases of the brain rather than disorders, then we may not know how to treat them outside of the medical model, which is medication. And we know that we can treat disorders with other approaches as well: behavior modification, humanistic approaches, dialectical behavioral therapy. There's a lot of different ways and approaches. So if we keep it disease-based, that's great. It's destigmatizing, yet at the same time, it tends to focus the treatment approach to being medication managed mostly. Dorothea Dix was also important because she saw the inhumane treatment of individuals and felt that treatment of mental illness people should be managed, with, again, humanity, with dignity and respect, and not to be imprisoned. Modern treatments today, from the 1960s, we started to develop psychotropic medications, and this fueled the release of patients into the community, and this is where community psychology has really built themselves within the world of psychology. At the advent of the 1960s and the Swampscott Conference, really starting to recognize and understand, we need to apply some support systems to individuals for mental health support, because we have these great psychotropic medications. People don't have to stay institutionalized in these hospitals. We can go ahead and release patients into the community. And even though there was more, humane treatments, there's still many people in the 1960s that were getting electroconvulsive therapy and lobotomy as a course of treatment. Lobotomy meaning you would excise or literally cut off a portion of the frontal lobe to help minimize the person's outburst. But it really did just change their personality and their behaviors. It didn't change necessarily the illness, but it subdued them. Deinstitutionalization practices, the current debate continues. Should we have certain inpatient hospitalization? Should we have people in outpatient and community clinic? Obviously, with severe mental illnesses, sometimes people can benefit from an inpatient stay or a short term, maybe 30 days, 60 days, 3 days, 10 days, right? But ultimately, the goal is to get folks back into community and society and to sort of function within their community, with their family, with their friends, within their society, within their neighborhoods. Now, the deinstitutionalization movement, a little bit more about that. People were released into their communities, but really, and the concern was, as people were released into communities, we didn't have a lot of outpatient services in the 1960s. It kind of got people out of hospitalizations, and we had great treatments, but we didn't have enough community-based services as we do now. So for about 30 years, between the 60s and 90s, it was definitely a struggle. We saw a lot of transinstitutionalization. Person would leave one hospital setting, and they might move from one institution to another institution to another. And there was frequently homelessness and jail time. And that still does exist today, where we know that the Twin Towers in downtown LA, even though it's considered a jail system for the criminal offenders, it does house more people with mental illnesses than any other institution in the United States. All right, so looking a little bit more at Bachrach's definition of understanding what deinstitutionalization means, or how we should think about it, that we should certainly have a depopulation of psychiatric hospitals and try to divert people into more community settings for outpatient treatment and interventions, that we should decentralize the responsibility, that, that's how it works right now, but it's very fragmented. You might have multiple diverse entities that are taking certain responsibility for individuals, like maybe you have a LCSW who's helping the person, and you have a case manager who's providing support. Then you have a vocation rehabilitation specialist. Then you have the Department of Mental Health caseworker who's also overseeing the case. So there's a fragmentation of authority. There's a lot of different people that are working. That's great. It's a multidisciplinary team, but it can also diffuse responsibility. What wasn't my fault the voc rehab person or the case manager, the DMH caseworker, but it's the LCSW. So unfortunately, it can account for some good support services, but there's also a lot of fragmentation as well. Community psychologists can account for the decrease in the quality of care in communities, or they can sort of start to investigate why we have poor quality care. And that's where community psychologists are very important, is to really start to investigate how do we improve the quality care of persons in the community that are receiving outpatient services. And so just an example of, that idea of trans institutionalization, where we have a lot of people that are living in a lot of different places. These are living situations for those with schizophrenia. And we can see that they range anywhere from homelessness to living with a family member to living in a nursing home to maybe into unsupervised living. Now, when we want to measure success due to deinstitutionalizations, we have to look at social integration. We really want to integrate people to become back to the part of the community. Recidivism rates, what is the likelihood that they're going to be repeatedly going back into an institution? We also have to have good community competency. In other words, they have to be able to live in our community, and the community has to be welcoming and accepting and have services, have the right amount of people that are mental health practitioners, homes, spaces, funding to provide skills training, vocational training, employment, right? We need a lot of services to help individuals, but unfortunately there is a problem of bias where clinicians may give different criteria for deinstitutionalization or for treatment approaches for a person depending on their racial and ethnic group. Now, we've talked about diversity in community psychology before, so I want you to revisit those ideas when we talk about sort of clinician bias and microaggressions that can come through in the interactive experiences with psychologists and community members. Now, there are definitely model programs that we know are great within the community, and community psychologists must be aware of understanding the different treatment modalities as well as understanding the best approaches that seem to be very effective. And I'm going to go straight to the assertive case management. Assertive case management, or ACT, really teaches people these individual practical living skills, right? Also a multidisciplinary team. I started to talk about that in one of our earlier slides, where you have a lot of different people with different areas of expertise that provide services together to provide intensive case management, right? So you have someone helping them build a resume, another person helping them with interviewing techniques, another person helping them with housing, another person maybe supporting transportation vouchers, another person giving clinical support, another person helping with family therapy, right? So we have a whole lot of different people with expertise that provide services. Different staff, usually home-based therapeutic counselors, vocational specialists, right, depending on what the needs are of the individual. They visit clients in their homes. We know that ACT is very effective. We know that 3/4 of the people stay and maintain to have long-term involvement with their case management experiences, fewer hospital admissions, and if they are admitted for fewer days at a hospital. They have better housing outcomes, less likely to be homeless, have better community functioning, and better feelings about themselves. They feel like they can engage and interact with the community, be a part of the community, and feel good about themselves. We also know that although this can be a very, very expensive approach, right, because you have these outpatient community mental health centers that are providing a lot of different services and hiring a lot of different staff with a lot of different expertise, we know that there's a reduction in hospitalization, and hospitalizations makes the program cost effective, because the cost for hospitalization is tripled that, and in some communities quadrupled that of our assertive case management. So just so you know, another model program is wraparound programs or wraparound services, where you get comprehensive programs for those at risk for institutionalizations. It models after the strength-based approach within the social work, where the person, you identify their strengths, you help them focus on their strengths and sort of build goals around their strengths. Family is highly involved. It's need-based, individualize service plan. So what are their needs? Let's individualize it to you. 24-hour urgent treatment teams can be put in place as well. Now, the interesting thing when it comes to the research outcomes here, residential treatment is dropped by 60%. Inpatient hospitalization drops 80%, and there's really good outcomes for youth, like our transitional age youth. Fewer criminal offenses, better school performances, and positive evaluations from their parents. Parents start to say, like, hey, my children or my teen is getting much better with these wraparound program. A wraparound program is, kind of think of it as a one-stop center where you can come in and get all these services met from this strength-based approach. Adverse childhood experiences is also important to take a look at. With adverse childhood experiences, we know that if you have 4 or more ACEs, then you're going to have a lot more complications. ACEs meaning abuse, emotional, physical, or sexual abuse, neglect, having family dysfunction. If you start experiencing these adverse child experiences before the age of 5, then you're going to have even more complications. You can see the infographic here. Even with just one ACE, you're compromised. But we do know that there's a lot of protective factors that can happen in a home for young children that can shield the impact of the ACEs, like maybe having really supportive grandparents, or maybe having enough, financial support and wealth, right? That might be it. Or maybe just having a stable home. So there are other things that can be part of a support system, even if you experience any ACEs or adverse childhood experiences. Now, when it comes to early childhood experiences and prevention, we have to pay attention to these different diverse developmental pathways. Everyone will develop in their own pathway and really kind of start to build who they are based on these developmental experiences. Your culture plays a huge role in your developmental pathway, and there is this recognition and understanding that if you have coherent social support systems that are sort of embedded into your cultural practice, those are very good support system as opposed to chaotic and incoherent systems. Now, the transactional model of development by Samaroff has been very important. And according to Samaroff, he says transactions are very important. They're omnipresent in our society, and everyone in the universe is affecting another or is being affected by another. And so, in other words, he was interested in trying to understand how that environment and how that influence of having these transactions with others would also have what is going on with our biology as well. How do these things interact together, the environment and the biology? How do they interact together to help produce these developmental outcomes? So there's a relationship between the parents and the children, not only environmentally and socially, but also biologically as well. And their parents are involved in many different ecological settings that are also changing and being changed. So this is interesting. What are the biological risks? What are the environmental risks? Now, your environment can be very risky and put you at risk for psychopathology. And again, Samaroff was really interested in understanding how these ecological contexts would lead to the development of psychopathology. But he also said you might have had biological risks, but if you have an environment that is promotive, in other words, promotes adjustment and functioning, then you may not even see those biological risks evolve and emerge. Early development intervention programs do work. So in other words, when you see a family that may be at risk and you have children under the age of 5, it's most effective with these early developmental intervention programs. If it's multi-year, it's not a one-time kind of deal, that it's multi-year. In other words, quarterly, monthly type of visits. And even if it's most intensive, where you have a lot more contacts with a lot of different professionals working together, like a wraparound program, the outcome effects are very effective as well. Children have better education, lower social deviance, and even better social and emotional development. And moving forward to the future, so our last slide here is the NAMI, the National Alliance for the Mentally Ill, have really been leaders in advocacy and empowerment and reducing any stigma. Focus on prevention and treatment is another area that we need to continue to move forward to, not just what are the interventions or the treatment approaches thereafter, but what types of things can we do within a community for prevention, and actually to seek out research in these natural communities, not these arbitrary catchment areas where earlier studies were conducted on, but really looking at all communities and trying to understand sort of the different types of pathology. Thank you for listening, everyone.